Good afternoon, everybody. My name is Regina MacArthur. I'm here to present the webinar for NAMSI this afternoon, and we'll be talking about simulation in EMS education, and particularly a simulation model which is based on changing the curriculum. Throughout the presentation, we do have Matt as a moderator. If you guys have any questions, just feel free to type them into the chat box, and both Matt and I will be monitoring those and we'll answer as we go. And I will leave about 10 minutes at the end for additional questions for those of you guys who have specific things that they would like to ask. I can also follow up with you after the webinar. I'll provide my contact details at the end, and then we'll also send out the recording. So Matt, we're good to go, I believe, and we'll get started. So the first thing I should mention is that I don't have any direct conflicts of interest other than I own my own business, which is a consulting company for education and patient safety. And I also work with as a consultant for multiple paramedic programs across the country who are trying to shift towards more of a simulation-based platform for their education. So my company is called the Vital Stream Group, and that is my contact information at the end. So that is the only conflict of interest that I have. So today's presentation, I really wanted to be part one of a three-part series, today being the most general of the presentations. And so today's goals are really to go over some basic educational concepts, which you guys have probably heard of, but are a little bit more specific in the realm of simulation in order to get your curriculum a little bit more focused. Secondly, we'll discuss the difference between student-centered instructional design to a student lens and the student actual perspective from an experience design perspective. Third, we'll go over different types of simulation experiences. Sometimes this is known as modes of simulation. And lastly, we'll list 4 ways to start changing your education program to optimize your use of simulation and to really start to build capacity inside your curriculum. So the first question I'd really just like to have you stop and think about is, what is the purpose of lab? So we all know that this comes from the PPCP and the National Registry as far as how we should be structuring our paramedic education to make sure that our students get the most out of all the experiences they have. Well, let's just think for a second. What have we typically done in lab? It's really been psychomotor skills, and we want to try to start to get away from that and move more towards scenario-based education. Well, why? What's the purpose? We want to build critical thinking. And so really, how do we get from point A to point X, Y, or Z, and what is in the middle? That's the real question of what we're supposed to be doing in lab, but there really hasn't been a great model yet to point you guys in the right direction as far as a pathway, right? What are all the little pieces in between doing an IV on somebody or an IV arm and practicing that and getting good at that, and actually integrating that into a full complete scenario which can be effectively administered and or evaluated. So many educators would say that the purpose of lab is to fulfill learning objectives. So the students have opportunities to apply their skills, to build the learner's confidence in themselves, in their team, in their own assessment or communication or soft skills. Some people use lab as a platform for problem-based learning. Now, we'll talk a little bit about problem-based learning. It's going to be more in part 2 of the webinar series. And hopefully none of you guys are saying that the purpose of lab is to fulfill our PPCP requirements. That is one of the things we have to do, but it is not by far remotely in the priority list, because we're really trying to make sure our students get the opportunities to learn. So why do we need a lab curriculum? Well, when we talk about a curriculum, we're talking about a collection of learning activities which really affords the student the opportunity to build that knowledge within their brain, and also to apply that knowledge in action for different types of contexts or situations. And so the purpose of needing a lab curriculum is not just to apply skills. It's not just to allow our students to have an opportunity to see those clinical situations that we talk about in lecture, to see a simulated chest pain patient, to see a simulated CHF patient. It is to link all of the concepts with the behaviors that they should be performing and doing in order to form schema, which we'll talk about in just a little bit, for the purposes of allowing our students to develop the skills to effectively treat patients and think critically about the situations that they're in, to effectively problem solve. So breaking that down a little bit further, from the instructor's perspective, what do students need to learn? They need to learn things like crew resource management, multitasking, situational awareness, how to monitor their team, how to be an appropriate team member and team leader with regards to the attributes that are outlined in the most recent research with regards to the National Registry global evaluation checklists. They need to learn how to be a patient advocate. They need to learn how to funnel and sift information that comes out during a situation into an accurate working or differential diagnosis. And lastly, they need to understand how to prioritize treatments and utilize their team efficiently to, excuse me, to effectively carry those out. So let's think differently about simulation. We framed kind of what our goal is, and that really is to allow our students to have a planned set of learning activities to go through as far as a curriculum for lab in order to develop their critical thinking and their problem solving skills. So we think of that as learning objectives or performance goals or competencies, what they should be able to do at the end of a program, whether that be broken down into one longitudinal pathway or whether it be broken down into multiple different classes that they have to take through a community college track. The students, really, when we asked them, said, well, we really need to learn how to do 4 major categories. First is we have to figure out what's going on with the patient, and that of course includes actions like assessment and monitoring and interpreting their EKG. And then we need to understand how to treat the patient. So those are things like protocols and drugs and understanding the pharmacology and how do we choose treatment A over treatment B and how fast should they get them. Also, how do we make the best decisions for the patients? Now, there are different types of decisions, and we'll go over those in part 2 of the webinar, which talks a little bit more about evaluating different types of learning activities. But in general terms, making decisions is really high up in the students' concern list of as far as what they need to learn how to do in lab with regards to treating a patient within a scenario. And then lastly, soft skills, things like patient advocacy, patient communication, family member and bystander communication, professionalism. Those things which are really evaluated in the team member and team leader attribute lists are also important to the students, because they need to not only learn how to act from the instructor's perspective, but they really need to understand how to communicate with each other. So I'm not going to delve too deeply into traditional learning theories or teaching methods. However, with regards to simulation and this particular presentation on how to effectively implement it in a longitudinal way across a curriculum, we need to talk about Vgotsky's zone of proximal development. And what this refers to is really when the student is ready to learn. Now, we all ask our students to come prepared with an open mind to learn something, but we know that we cannot teach them how to, for example, integratedly treat a severe CHF patient without first teaching them the building blocks, making sure they understand how to interact with the equipment, making sure they understand that, you know, oxygenation is more important than some other concepts, you know, assessing the belly, for example. So we need to make sure that students are in the right place to learn. Are they ready to learn that concept? And as educators, we've been really taught to think about that in a prerequisite mode. So has the student learned the prerequisite knowledge or information to receive this lesson? Well, really, it's has the student process that information to the level where they are now ready to adopt and add to their mental model or to their frame of reference, right? Do they understand the oxyhemoglobin curve before we give them a hypothermic trauma patient? Or is doing that hypothermic trauma patient going to be too difficult or too complex enough in debriefing that there's really no point to us in discussing it and, quote, wasting that time during our lab with the learners? So we need to make sure that with regards to proximal development and cognitive readiness, our students can really adopt and take in those next pieces of information or that next challenge from a psychomotor or an affective standpoint in order to then affect that learning or turn that light bulb on in their brain. So that's pretty much the basis of a lot of planning with regards to simulation. And the concept here with this image is really that simulation and a curriculum is almost like concept-based learning. It's experience-based learning. It is all linked together, right? So how do we forge a pathway through this maze of activities or through this maze of content that we as educators need to make sure that we expose our students to? And along the way, how do we ensure that the students can take that information in and do something productive with it? Meaning learn, meaning apply it to something, add to a existing mental model, and build upon the knowledge that they already have. Well, we know that adults learn differently than children. So there may be different pathways for each person through this maze. So how do we go about building the best experience for all and to kind of try and keep everybody within the relative same swim lane without running each other over? That's the student perspective, is how do I get through this? The curricular perspective is how do I fit it all in? How much time do they expect me to plan? How much time do I have? How do I fit it all in without sitting their butts in seats and lecturing to them? We know that we want to optimize our efficiency of our program in general by having a balance. We need to have a balance of experiential learning. We need to have a balance of visual or auditory learning. That's just the traditional educational methods. There are some programs that have been very successful with flipping their classrooms completely and kind of pushing that responsibility out to their learners. I don't know about you guys, but it's been a rough road for many programs trying to implement flipped classroom. And so a lot of people are trying to say, hey, we're trying to do more simulations, but there's just not enough time. There's just not enough faculty. How do I get everything into the time that I have, and how can I make the most of that time? So let's start talking about how we can optimize that time and start to build in some efficiencies. When we develop simulation programs, we really need to think about capacity, right? So you make a small change, and that change, if it's a process change, will ripple throughout the whole pond and build capacity and allow for greater time savings overall. So it really exponentiates over time. So don't be afraid to make small changes. If you make them across multiple learning activities or multiple lessons or multiple weeks, you'll see yourself saving 8, 16, 24 hours of other time, which ultimately may have been used for lecture or something else that may have not have the gravitas when it comes to the amount that it allows your students to learn. So the goal is really to change to a concept-based curriculum which is grounded in affective and psychomotor behavior or activity. And traditionally, as we as educators have gotten into the simulation world, our scenarios have really been randomly planned, by, if they're planned at all. We bring in the instructors that have traditionally done labs, and we say, hey, today they need to have a chest pain patient or a CHF patient or an abdominal pain scenario. They're very treatment focused. Our instructors are not used to cutting a situation early for some educational purpose. They want their students to be thrown into the deep end, to have to do everything all at once. And this is really overwhelming to the learner. Why do our instructors do that? They do that because that's what they do in the field. The majority of them are clinical preceptors. They're used to hot washing the students, giving them quick and shallow feedback about what their performance was and how they can improve. And then they go right back to either the next call or to the station or to the next hot meal. And the student really doesn't get a chance to examine their decision-making processes. It's really just about hot washing the whole call. And traditionally, simulation and scenarios have really been to supplement lecture. Lab has been that add-on experience to really the core content, which was instructor focused and information focused. We want to transition our programs over to affective and behavioral psychomotor based curricula, which means our activities, not necessarily our scenarios, because there are different types of activities which we'll go over other than scenarios, which are very deliberate. Every activity that we do with the students is deliberate. It has a purpose with regards to where the student is in their learning pathway, where the class is, what the next challenge is. We don't want our students to be comfortable all the time. We need to push them to the limits. That's the whole point of the zone of proximal development. We need to keep them comfortable for just as long as it takes for them to realize that they don't know everything yet. They don't know what they don't know, and then we push them to that next level. We'll talk about that here in just a little bit. We want to move our scenarios from being traditionally treatment focused to really being schema focused. And we'll talk about what schema are. Schema are really groups of linked concepts or linked activities. So we want our simulation and our scenario activities, our psychomotor activities, to be focused on developing a piece of the student's affective behavior, psychomotor behavior, piece of the puzzle. We don't want them to just come in today and build the puzzle completely. They can't do that from the very beginning. Throwing them into the deep end does not help them. We want, instead of a quick hot wash, we should be doing integrated debriefings. Now, the depth of the debriefing does not necessarily mean it needs to be deep all the time, which means to the full depth of the scenario, the full scope of the scenario, but it needs to involve the full scope of the situation. It needs to involve the depth of proximal development. What are we trying to actually achieve in our learners at this point in time? Are we really trying to get them to go all the way through the end of a CPAP scenario to treat a CHF patient with pharmacology and with CPAP and with positioning, and with full team delegation and utilization? No. Maybe today our goal is really just to get them to efficiently place in a certain amount of time. We want them to do a primary assessment, recognize that the patient has critical airway, breathing, and oxygenation issues. We want them to apply high flow oxygen, realize that their patient's level of hypoxia is not improving, and then we want them to realize that they need to go to that next level of applying PEEP instead of just increasing the FiO2. So the schema there is not treating a CHF patient. The schema and the debriefing needs to be about the patient's oxygenation, about ways to improve airway oxygenation and ventilation and perfusion with different tools and techniques, and what feedback the patient will be giving us, whether it be skin signs or mental status or diagnostics, end tidal monitoring, respiratory rate, all these different things. What feedback should we be looking for in the patient? So our schema is associated with monitoring and treating ventilatory and oxygenation emergencies, not necessarily just how to treat a CHF patient. The CHF patient becomes the tool at that point in time in order to develop that schema within the learners. And it's important as we talk about simulation that we don't just say the word scenario. As you can see here in the second column, when we talk about a psychomotor curriculum, we're talking about pieces and parts, which ultimately will then constitute pieces of a whole EMS call. But we don't necessarily need to run through that whole call at that moment in time in today's lab. We need to make sure that we are growing these students over time and not just expecting them to swim in the deep end. Ultimately, this will probably replace lecture. We know that from the research, traditional apprenticeship models of learning are very hierarchical. It's related to the instructor and the student's relationship, and it's very dependent on that. While a psychomotor curriculum allows for students to rotate through, to serve in different roles, to serve as team leader, to be an observer, to serve as patient advocate, sometimes to serve as evaluator or mentor. So this will ultimately replace lecture because our students will be able to learn in various different ways and also have input from various different instructors. We'll talk about instructor as facilitator here in a little bit. So this is a kind of a rapidly moving presentation, but how do we get our program to start transforming? How can you guys move towards an integrated curriculum model? So we'll give you 4 starting points today, and some of these will delve in deeper as I go into other webinars in parts 2 and 3 of the webinar series. But really, the 4 concepts I would like to introduce today are number 1, we want to introduce simulation in meaningful bites. And I don't mean introduce it to the students. I mean plan the curriculum into experiences which are meaningful, which utilize that zone of proximal development. What is the student ready for? What do we need to challenge the student with because it takes so long to learn? Secondly, we need to make sure that as we look at our curricula out there, we're addressing the students' cognitive load. This isn't just about putting them into situations which might make them overwhelmed in a psychomotor standpoint, but are we giving them too complex of situations or cases to where it just overwhelms their brain and they can't learn at all? Third, we can use multiple simulation modes. Not all simulation is small groups rotating among different instructors. That's actually a great way to use simulation, but it is by far not the only way. And it is a very, very instructor reliant model in that you need an instructor for every single small group. Every single instructor needs to kind of be trained up to a specific level on how to use simulation, how to use the mannequin, how to run things so that it is student-centered and not instructor-centered. How do they do a debriefing? So there's a lot of faculty development that needs to fall into place before programs can really be effective with using small group simulation every single day. And so we'll talk about multiple simulation modes and some different ways that you guys can start trying other activities in your labs. And lastly, we'll talk about flipping the classroom. We're just going to mention this one because it really dives into a whole nother topic, which could be its own webinar. But there are some schools that use it really, really well. And NAMSI has some great resources with regards to flipping the classroom. So let's talk about the first solution, being meaningful bites. From a pragmatic perspective, we're going to organize the content on the plate that we're going to serve up to the students, and we want to cut up the food. Right? We don't serve toddlers full pieces of pizza or full birthday cakes because there's a lot of mess to clean up afterwards. So we want to make sure that as students are trying new things, they're not overwhelmed. So what are some of the things that can create complexity and create disorganization in the students' brains? Well, their assessment. We need to really get them focused on an assessment process. How many of your students have asked you guys, hey, how do I create a template for doing the right assessment? How do I create a template to take into an oral station so that I remember, to make sure I ask all the right questions? We need to get some of these things early onto the students' radars so that they can practice and hone them, because it's really going to become the core of their behavior and the core of all of these other things that they're going to add on to the experiences and to the behaviors we expect them to do. So assessment is really at the core of the content and the behaviors that we're trying to affect, right? And by assessment, it's a general term, right? Some cross monitoring, assessing the situation, situational awareness, right? Not just assessment of the patient, right? It's managing the situation. So what are some things that can create complexity in the students' minds? Well, how hard the case is to begin with. So at the bottom there, we have complexity, right? Is it a simple patient who is going to improve with nasal cannula oxygen, or do we need to go back to the patient's oxygen multiple times because they keep decompensating and they ultimately need, assisted ventilations? Those two scenarios, although they're both respiratory distress scenarios, really are quite different in their complexity, especially with regards to the student, because they need to think about multitasking. It's not just a simple cause and effect. I see dyspnea, I hear wheezing, I put on oxygen. We need to make sure that we are starting with a lower level of complexity, and increasing difficulty level is one of the things that early on in simulation came out in the research as being effective for learner development, is increasing complexity over time as the students are ready for it. Time of endeavor. The more students are towards the beginning of the learning process, right, the less confident they are in themselves, the less amount of time they're going to feel confident in being in that leadership role. And so I challenge you guys to think about, is it more beneficial for one student to have a 45-minute or a 30-minute learning experience where they're the team leader, or is it more beneficial for everybody to have a 6-minute learning experience where they also get the benefit of observing their peers and watching, learning through observation, learning through repetition, to see other ways that students might approach the same problem. So time of endeavor also increases complexity in the students' minds. The number of decisions and the type of decisions the students need to make will during the case. And I don't just mean treatment decisions, right? We can make some really great scenarios with regards to extrication decisions, or even just movement out of a basement for a patient who needs to, remain upright, but it is, too large to fit on a stair chair. There's great situations where you can really challenge the learners with situational context. And so these are just some of the things that we need to think about when we are designing learning experiences. Solution 2 is to take and to feed them small, meaningful bites, right? So from the learner situation, they're going to dive into whatever we give them, but they need to be ready for it. We can't just throw them into the deep end and expect learning to be effective. So I'm going to use a generic term here called mini sims, which I'll give you a list of different types of them here in just a little bit. But we're going to take many forkfuls of content and give it to the learners over time. And so they can increasingly become more complex, but really repetition is the key, and training and structuring your lab around these meaningful bites, or these small pieces of content or schemas. Behavioral bundles maybe would be a great way to put it, can really benefit your learners. So let's look at what types of activities we can give them. Now this is a very, very busy slide, but let's kind of look at the two columns at the top. We have team development and individual development, where we are definitely trying to develop them at both levels. We need them to develop as individuals, because they need certain skills. There are things out there that they're going to be responsible for that nobody else on the team may have the content or scope of practice to interpret information, EKGs, for example. And then there's team development. We absolutely depend on our partners more than ever nowadays, and we need to make sure that we are allowing them to develop not only as strong individuals, but as strong members of a team, whether it be an EMS team or a multidisciplinary team where they're working in a hospital or in a critical care situation. So starting at the bottom, we can have scenarios which are small. Many of you guys start your programs with BLS cases, with BLS scenarios at the beginning. I think that's great. We want the students to be exposed to the need to perform, the need to try, the need to put themselves out there, and to fail forward. So elemental scenarios being those scenarios which are foundational, the scenarios which should reinforce what they already know and maybe even open up their brains to a little bit of what they don't know. We are used to, on the individual side, spending a lot of lab activities and time on motor skill practice and fundamental skill mastery, getting good at putting the CPAP on in a timely manner, getting good at starting an IV, getting good at dicing a drug and administering a medication. But are we good at doing all of those things together in a bundle? So if we look at the parallel activity on the team development side, I would argue that we don't necessarily have to spend time dispatching a student or a team to a CHF scenario. We can literally give them a situation that they walk into. You know, you walk into a home, there's a labored breathing patient on the floor, middle-aged female, you hear rails, go, right? And if they're to the point where they've learned what some of the priorities are, they can make those decisions and decide amongst themselves what needs to be done. But it is not inappropriate for you to say, you have 3 people, you need to achieve A, B, C, D, E, and F in the next 5 minutes, go. And just that situation and allowing them to get good at those types of things, those bundles of care. How do we optimize airway, breathing, and circulation for the guppy breathing anaphylactic patient that you find with a phone in one hand and an albuterol inhaler in the other, or an EpiPen in the other? How do we get them to bundle those things together efficiently? Allowing the students to kind of have those opportunities and to almost gamify the ability to get good at them not only builds teams and increases communication, but it is building those building blocks that we will need them to then place into those scenarios later, where we give them those difficult CHF scenarios where they need to balance you know, their entire assessment with that treatment bundle or that performance bundle. So we want to make sure that we're giving them parallel activities starting at the bottom here and going up in complexity. So just to list out some other ones on the individual side, we need to do decision drills. Again, they don't need a whole scenario for this. It can be a situation. It can be built out of a clinical review or a clinical chat. What calls did they have? What decisions did they need to make? And why were those decisions critical to the patient? And which decision did they ultimately end up making? Was it right? Was it wrong? Let's talk through that. You guys know, as the experts, that there are decisions that come up over and over and over again in the assessment and treatment of these types of patients that we see that fall into protocol categories or treatment categories or differential diagnoses that we really need to drill home into the learner. Never will I ever lay flat a patient with rails and respiratory distress, et cetera, et cetera, et cetera. So, but I mean, are there some situations where we need to consider that? Well, sure, if there's an extrication issue. So we want to talk out those decisions either, at the individual level or at the team level. Can that be done in multiple different ways? Sure, it can be done in the classroom, it can be done in lab, it can be done using different tools that are out there, curriculum tools where those things are already spelled out. So decisions are a critical piece. Next is illness script interactions. Now, if we look at those words, what an illness script is the picture of that disease or that problem in your head. So you are all experienced EMS providers. If I said picture the last critical CHF patient you had, you all have the picture of him or her in your head, right? Our learners don't necessarily have that yet. They aren't sure what should be on the list of differential diagnoses for a patient with that problem. They're not sure which pertinent positive questions to ask, which pertinent negative questions to ask. So illness script interactions are activities that are focused solely on allowing the students to differentiate and contrast a specific problem from another. How do we distinguish CHF, acute CHF, from pneumonia? How do we distinguish simple hypotension from gastroenteritis from sepsis or septic shock? So illness script interactions are activities built specifically around differential diagnosis. Again, going back to what makes a scenario hard to students, that's what we need to focus our activities on. So a dimension of that is figuring out what's wrong with the patient. How do I know which questions to ask in my assessment? The solution is to do activities focused around the illness script. Next, on the kind of individual development and team development side, there are some programs out there where you can do mobile click-through patients, right? And they get the experience of doing individual problem-based learnings or case studies on different types of medical problems. From a lab situation, we can put students through at either the individual or the team level for the next activities, developmental scenarios, those scenarios that really develop the student's learning, develop the student's frames of reference, why they should be treating the patient like they should be treating the patient, how to add on additional information to what they already know. And then lastly, the two levels at the top are really kind of head to toe, beginning to end scenarios. So scenarios that are meant to be reflexive or reflective, to where the student can look back and say, okay, this is why I made the decision. They can start to justify and put all those pieces together. And then lastly, from a team scenario standpoint or from an individual evaluation standpoint, we're building these learners up to that integrated out-of-hospital scenario where they are delegating to a partner. So why do we do this? Well, we need to manage cognitive load, and when we really break down cognitive load into its factors, we're talking about working memory, how much memory I have to make a decision or to deal with the information that I have. How much information do I already know about this situation that I can pull from other experiences, whether they be the EMT experience or from schema I've already built. If I've already built with my team the ability to treat and manage a cardiac arrest from a pit crew CPR standpoint, then adding on the intraosseous and the medications shouldn't be that difficult. But if I haven't yet mastered the pit crew CPR piece of it with my team at the BLS level, how can I be expected to then balance all that additional information? So when we think about complexity, cognitive barriers, and cognitive load, we need to minimize confusion. We need to minimize the amount of thought required. And the way that we do that is to make sure that we're training into them the behaviors, the care sets, the performance bundles, the decisions that they're going to need to make in this particular situation. So cognitive barriers are the number of steps I think I'm going to have to do. Do I expect this to be a hard scenario, right? Do I expect them to take a long time? And how hard is each step I need to take? So if I've practiced these things in isolation, then my perception of how hard it's going to be to put CPAP on or to do PICC crew CPR is going to be less than if I haven't practiced it a lot. When we talk about cognitive barriers versus cognitive load, we also need to consider the number of choices we're giving the students. And I don't really mean the number of choices that they have, but I mean the number of things that make the scenario complex. So do I have to manage a cardiac arrest? Or do I have to manage a cardiac arrest, you know, upside down in a creek in the middle of the night in a car? So those are the things that really we need to think about when designing our learning experiences for the students. So we want to scaffold their learning. This is the zone of proximal development again, with prior experiences that they've had from an adult learning standpoint, but also the prior experiences we've given them. Have they practiced enough to then put that situation into a scenario? Have we examined their existing frames of reference? Have we asked them questions about what they know about things or what their assumptions are before we then try to instill new concepts during debriefing? Have we developed activities that are going to build capacity or create schema? So a schema is this bundled stack of books together, right? If I'm only looking at running a marathon and I haven't done training for it, running a marathon at its full length is going to seem really, really hard. But if I've worked up to that over time and given myself a training regimen and planned this training regimen into the students' experiences, then when they get to run that marathon, they're not going to hesitate, A, to either start running, or B, believe that they can do it because they know that they've had all of the pieces. And the other benefit is that as schema or these bundles of knowledge or bundles of performance are created in the students' brains, they really go from something which may have been 10 steps to automated performance or automated goals. And so this is the goal of schema formation within our learners' brains, is to really create automation, something that they can do second nature as all in one. So they don't have to think about treating a patient's oxygenation as 7 different steps. They think about it as one step. And it is second nature to them after they place oxygen on the patient to look back at their diagnostic monitoring, to count the patient's respiratory rate, to look at the tidal volume and listen to lung sounds to see if they've improved. It is a care set that I'm not just going to go through the process of asking about PDE5 inhibitors and taking a blood pressure before I give nitro to a chest pain patient. It is automated that I automatically do those things. So it becomes one thing instead of 7 things, which frees up more working memory for the student to learn other things. So that's the second solution, is really to take in cognitive load and the zone of proximal development into account. Solution 3 is to use different modes of simulation. Right now, here we have a box of Legos. It's one of those 3-in-1 creator sets. And what's interesting is they come with directions for all 3. And I challenge to allow your students to play with one of these in a group one day. There are some groups that will start to just build their own thing. There are some groups that may break off and each of them will try to build all three things before they realize they don't have enough pieces to do that. And then there are other teams which will come together and choose one and follow the directions. But what's interesting is we as curriculum planners, as program managers, as instructors, can use different modes of simulation for different things. So to one student, this box of Legos is going to look great to build a helicopter because that's what they're focused on at that main point in time. They're concerned about how to treat that patient. There are other students who really know that they might not be strong in assessment skills, and they're going to look at this box of Legos or simulation or scenario or activity and say, I really want to focus on assessment today, and that's what I'm going to pay attention to. So I'm going to build that airplane. And then there's other students who realize that they're just really not good at speaking up or giving orders or commands or taking control of the team, and they're going to build the sailboat. And so what's interesting is giving a student one set of tools, but using them in three different ways. Each student will get three different outcomes or three different experiences or perspectives, not only on other people's learning or the content itself, but their own learning. So what are some examples? I know I speak a lot in abstract terms, but what are some examples of ways that we can use simulation other than in small groups? Because that's what we all think about when we think about simulation, and that's really what our frame of reference has been, is how to get them into small groups, because that's ultimately, how they're going to be tested. So think about this the next time you're planning an activity. Can we use some of our lecture time to do a live simulation in front of the classroom with group A or group B? And every week, every group has to prepare because the instructor randomly picks a letter, right? Or maybe if they did great last week and they've done some extra preparation, right, they get amnesty for next week. So you can motivate them in different ways to hone their own performance as groups, but there is a benefit to putting them in front of the classroom. Now, there has to be some things in place like safe educational environment, Facebook video, things like that that we protect our students from, and it needs to be, everybody needs to understand that there are going to be mistakes and everybody's going to seem like a goofball and ridiculous on some days. They need to not be afraid to fail. And so rotating them up front in order to allow students to benchmark where they are and internalize if their performance is meeting and staying on par with the rest of the class is really important, because our students are competitive. Many of them are type A personalities, and so putting them in front of the class is important. What is critical, though, also when we put our students into groups is making sure that we're rotating who the team leader is. So I'll just say that that's one way to use simulation or scenarios in the classroom. Think of it as psychomotor-based Jeopardy. It doesn't have to be a patient. It doesn't have to be a full simulation or a scenario. It can be go do this right now with the mannequin, or we're having time trials today to make sure we do this correctly. Next can be mini videos. So have groups create a video. They practice repetitively to try and make the best video possible, make it a competition. You get some great skills videos out of it too as well. And by skills, I don't always mean individual psychomotor skills like we have skill checklist sheets for. I mean bundles, right? So how to, what's the first 5 minutes of treating a patient with suspected acute coronary syndrome? What's the first 5 minutes of treating cardiac arrest? Group mini videos are great. Video critique is another way, right? It's a way to leverage simulation, whether you're videoing the simulation in a particular lab rotation from the week before, and the week following everybody has to do the video critique of it. There's great things that can be learned from video, whether you guys do a critique as a group with a discussion, or whether you assign videos out individually of the students' videos or the group videos, or one full video that the whole class has to do. Do they journal about it, right? What are they going to improve? What's their own personal journey along simulation? Journaling can be very, very powerful when it is, a protected communication technique between the instructor and the student. I know it's a lot of work on the instructor's part, but you really get a good sense for how your students are journeying along the pathway, how confident they are, where they feel like they need more help, where they feel like they need more support. Large group debriefings. Large group debriefings are interesting because everybody at the beginning is kind of starting from the same place. You don't have a lot of variation, and you don't have students very far ahead of others with regards to their performance. So at the beginning, we can build efficiency and we can build capacity by taking debriefing as a group activity instead of delegating that to instructors who may and probably are not that familiar with debriefing to begin with. So modeling that debriefing process for them in the beginning of the process of simulation and unfolding this out can be a great faculty development tool for them as well. So large group debriefings. All three groups of students can do the same exact scenario. They can do different scenarios, but if the goal is cardiac assessment, does it really matter whether it was a STEMI and NSTEMI angina? No, it doesn't matter what the patient was, because our goal is assessment process, talking about pertinent positives, pertinent negatives. So debriefing the learners in large groups can save a lot of time, and it allows you to double the number of simulations that you can actually achieve and do early on. And so remember to limit the time for the simulations to what your goals actually are. They don't have to be full patient scenarios. You'll lead up to those, you'll build up to those over time, and as your content gets more and more complex, as the students become more automated with those smaller pieces of bundled performance. Praxis. So praxis is not the same as practice. Praxis is a concept that really leverages a facilitator's ability to communicate with the learners. So praxis is a great process for discussing variations in situations. And this is an important concept when it comes to flipping the classroom or problem-based learning, which we'll get to in a second. Praxis is discussing variations in the situation that was shown to maybe discuss solutions for similar situations, right? So we all have those cases that we give to our students, and then afterwards we say, well, what if this had been the case? What if the patient didn't want to go to the hospital? How would your communication, how would your assessment, how would your treatment change if this were the case? And so praxis is a very, very actually old concept used in problem-based learning and used in reflective practice, which is very, very common in healthcare education, but it's traditionally been used to discuss ethical concerns and professionalism issues, so soft skills. But we can also utilize it in scenarios where differential diagnosis may change the treatment for a patient. So Yes, our respiratory patient requires a respiratory assessment. Yes, they require respiratory monitoring, right? But how would our line of questioning or our pertinent positives or pertinent negatives change our treatment decisions if, the patients complained also of a fever? So it doesn't just have to be differential diagnosis related. It can be situational, it can be contextual. And so praxis is another one of those concepts that have been out there a long time and that we've been using it, but we don't really plan it in. And the value of planning it in is that then we cover the content. It's a planned, designed curriculum, right? I can give my student a flipped classroom where they're doing all of their reading, doing a pre-quiz, and today they come in and do 4 different stations. One is a skills or a team bundle practice station for pain management and hypotension and the acute abdomen. One patient is an appendicitis, one patient is a Crohn's disease, one patient is a gastric ulcer with vomiting blood. So we can talk about in the appendicitis debriefing variations for other organ problems. We can talk about presentation for appendicitis different than for gallbladder, different than for kidney stones, different than for ectopic pregnancy. In the Crohn's disease, we can talk about diverticulitis, ulcerative colitis, et cetera, et cetera. So we can cover that content in the variation debriefings from the flipped classroom activities. We don't always have to deliver the content in lecture and then in lab. It's impossible for us to show them everything. So the last bullet point here is just to start to think about and the differences between problem-based learning and simulation. So problem-based learning being more based in the student's experiences, and yes, it's situational, yes, it's experiential learning, but it doesn't always involve action, right? Problem-based learning can be case studies, it can be video-based cases, snippets of the Facebook videos that show how attention pneumothorax works. These are all problem-based learning. It allows the student to relate a problem to a concept that they have learned, versus simulation, which is meant to then ultimately show performance, behavior, bundles of treatment, end goals. So problem-based learning is a great tool that can be a part of simulation-based learning, but it is not a replacement for simulation, nor is simulation really replacement for problem-based learning. So those are some solutions for you. I know that we have time to consider. So think longitudinally about your curriculum. How do you eat an elephant, right? One bite at a time. We want to look at assessment actions and variations. How can we bundle them together, and how can we introduce them earlier in smaller bites so that the students get the repetition, right? They're not going to learn EKGs in 2 weeks. They have to have repetitive practice over and over. We can't just do one lab on needle crike. We need, implementing a needle crike into a scenario. They're going to need to have a situation or a scenario that integrates that once a semester, once every 3 months. And when we look at the literature for simulation and skills retention, the earlier the student has exposure to that skill and the more frequently they're practicing, obviously the better at it they're going to get. So we need to make sure that we balance the activities that we're giving them with also what they're going to get in the field. Yes, it's important for them to practice IVs, get up to a competence level, but then they're doing enough in the field where we don't need to evaluate them anymore in class on their ability to do an IV. So why do we keep doing IV lab? Why do we keep doing, you know, airway lab for, you know, King Airways, when we can integrate those things into bigger care sets, bigger performance bundles? Introduce some things longitudinally. EKGs, diagnostics can be longitudinal. They're going to be using them for every single patient contact they ever have in their life. Same thing for pharmacology. Introduce it early. Drip feed the content. You can align it with the types of patients you're giving them, but start those things early. Look at where you can build some efficiency. So lastly, flipped classroom. I encourage you guys to try this with abdominal pain, with small group simulations, maybe using those examples that I gave you. We want to reinforce the small bundles. If you don't have enough instructors to do, you know, 4 simulations, that's fine. Put them into some peer learning activities. Put them into some video, a video-based, you know, review activity. Those can be in small groups. And I encourage you to measure the learning, right? Measure the learning. Give your students a quiz before, give your students a quiz afterwards, right? It's not going to be the same questions, but it needs to be the same level or the same difficulty of questions so that we can, so that you can see the value. Ask your students the type of learning they like to receive. All of them are going to say, we love doing stuff. We hate sitting in lecture. We like when we can do it. Do performance-based Jeopardy, right? These are all those different types of activities that you can give them to develop them at the individual and at the team level. And we need to make sure that we're planning them strategically. So again, building them from simple to complex, getting them prepared for that integrated out-of-hospital scenario, building our learning activities not just necessarily around the medical content, but around the bundles of what we're expecting of them, those decisions they're going to have to make. What are the situations in EMS where team performance really matters? You know, PICC crew CPR, the critical trauma patient, the critical airway and ventilation and oxygenation patient, the patient who, you know, is running runs of VTAC and is complaining of crushing chest pain. There's a lot of things that need to get done in a short period of time. It's not always time driven, but a lot of times just from the nature of our business, it is. So to look at where you guys should go from here, I encourage you to try some of these things. I encourage you to please reach out and get in touch with me. I am willing to help you along the way. My background is not only in education, but also in specifically in simulation. I've done simulation out of hospital, in hospital, with different types of care teams as well as EMS. And also, I have a lot of experience with curriculum planning. And so those of you that haven't really cut up a curriculum yet and started to look at the bigger picture, there are some checks and balances that you want to put into place. You can't just start changing stuff. You all have deans and graduation rates and attrition rates and National Registry pass rates to live up to and make sure that you're not disturbing. And so program planning and changing, it does require a lot of planning, but there are checks and balances you can put in place. We can put active monitoring controls. You can listen to your faculty. You can listen to your students. We can drip feed some of those things where if we're making one ripple, that buys time across 8 or 9 different labs in your semester. It requires faculty development and training, and we really can't change the way we're teaching or the way the students are expected to learn without developing our faculty. And sometimes we expect our faculty to really adopt it right away. Sometimes there's a little bit of a pushback. It all depends. You guys know how well trained your faculty is and how much they love to change. but it can be done. And there are resources. More and more, many companies are out there putting these resources out, making them available, so that you guys don't have to recreate the wheel and reinvent everything from scratch, right? Why bake a cake from scratch when you can just go buy a cake mix and add 2 ingredients, right? Now, sure, there's some situations where you have gluten intolerant people and you have to use applesauce, or you want heart healthy people and you're going to use, you know, olive oil instead of butter. Sure, there are those situations, but ultimately we can still use a cake mix. And so when we look at simulation and how to really spread it across a curriculum, you know, there is a pre-made, ready-made cake mix out there. We just need to tweak it for your specific student group, for your specific faculty, for your specific situation, with regards to all the different factors that, you know, you normally take into consideration. So I'm happy to send you guys articles, references. Here's just some of the references that I've used to put together this page. I encourage you to attend some of the other webinars that I'll be giving in the webinar series. This one was really just a splash into simulation, but I really wanted to leave some time for questions. If you go onto my website, which is vitalstreamgroup.com, and sign up, we do a quarterly newsletter for simulation, and right now it's very EMS focused since everybody's transitioning over to PPCP. I've recently changed my last name to MacArthur, so if you knew me as Regina Arnold, that's the same me. And here's my contact information. I encourage you to reach out and get into contact. So go ahead and put any questions you guys have in. I know we're kind of short on time here. Just let me know if you have any questions, and thank you guys all for attending.
All right, thank you very much, Regina. And thank you to everybody who came here and listened to the webinar. Looks like we have one question from Robert Sullivan. How do you recommend formative or developmental scenarios be graded and count towards the NREMT portfolio? I don't know if you want to answer that.
Sure. I love your question, Robert. We're short on time, so email me. But actually, our second webinar in the series, I think, Matt, which we were planning for either April or May, is actually going to be on evaluating scenarios. So each of those dimensions that I talked about, decision making, performance bundles, there's actually a way to teach it and there's a way to evaluate it. And so I will go over that scoring and also the more specific. But Robert, if you want to get in touch in the meantime, we can certainly go over it more in depth. But yeah, there are basically dimensions, and each dimension you can score. And that goes from a design standpoint, from a complexity, you know, how difficult are we making the scenario? Because then that obviously transitions over to the score that the student, you know, will get. They're going to get points for just like the Olympics, right? The harder the moves they do, the more they can mess up because they're trying at a harder level. So there is a way to do that, and that'll be our next webinar.
All right, so we'll wrap it up. Be on the lookout for an email for part 2 and part 3. We'll get those scheduled and on the NEMSI website as soon as possible. Our next webinar will be by Amy Eisenhower, and that'll be on March 21st at noon Eastern Standard Time. So once again, thank you to everyone for joining us, and we'll see you next time.